Welcome, everybody. It's great to have you here today. We'll go ahead and we have a couple announcements before we dive in. If you can go to the next slide. So as people are filtering in, please type into the chat your name, organization, and your county. And as a reminder, I'm Dr. Lauren Schumacher. I'm one of the child and adolescent psychiatrists. So I staff the CAP portal on Mondays now and also help out with the Echo. And Dr. Jung is currently away at a conference, so she won't be joining us today. And then include in the chat how your mood is right now using the very scientific rubber ducky scale. I think I would put myself maybe a 4 right now. Doing okay, but a little off balance at times. All right, and we'll go ahead into the next slide. We have a couple announcements. So as a reminder, please keep your cameras on. One of our goals here is really to help foster a sense of community, and getting to see everybody can really help with that. So we know this is during lunchtime. We encourage people to be eating lunch, and we're all used to now eating on camera. So please keep them on. We'll be recording the didactic part of the presentation only, and the recording will be available on the CAP website. And remember, this is really an all teach, all learn experience. We are really grateful to our case presenters. And if you've got a case to share, please email Joanne Jung to share the case. And as a reminder, you can get to do the mock part 2 credit without doing the post test if you present a case. Next slide. Additionally, we have a new Echo series coming. So this Echo series is on brief, effective tools and communication pearls for use at home, school, or in clinic. So this is going to be an interdisciplinary collaborative Echo dedicated to active learning of skills and interventions to serve as a bridge for youth, teens, and families awaiting services for common behavioral health conditions like anxiety, depression, and ADHD. And the idea of this Echo is really to help teach some of those skills and that you can share with families and teens, things like special time or different strategies parents can use to help with managing ADHD behavior, strategies to encourage in teens to help manage anxiety or depression in that time while they're kind of waiting to get linked with therapy. The new Echo series, as you can see in the chat, is going to be on the 3rd Thursdays of the month from noon to 1. And you can use the link here. We've also sent out an announcement email that has the registration information as well. All right, go ahead to the next slide. So we're very excited today to have Dr. Riederer here talking about depression. So she is a clinical assistant professor of child and adolescent psychiatry at UCSF, and she's the CAP Associate Director for Community Outreach and Engagement. Her clinical focus includes inpatient consultation liaison psychiatry at UCSF Benioff Children's Hospitals and Benioff Children's Hospital, Oakland, as well as consultation to primary care and outpatient psychiatry. She completed her medical school training at the Icahn School of Medicine at Mount Sinai, adult psychiatry residency at New York University, and child and adolescent psychiatry fellowship at Stanford. Thank you so much for being with us today.
Thank you, Dr. Schumacher. I am very excited to be here today to be talking about pediatric depression. And just looking in the chat, it looks like there's, we have such a lovely range of folks from nearby us in the Bay Area and also far. So just want to express my gratitude for sharing your time with us today. And I look forward to a really rich discussion with our case presentation. So to start off, I don't have any financial relationships to disclose and just need to disclose that UCSF CAP is supported by some federal and state grant funding from HRSA and DHCS. So in our brief 15-minute presentation, I hope to accomplish a couple of goals. So one, I'd like to review the presentation of depression from a pediatric standpoint, and by that I mean from a developmental perspective as well. Then help to differentiate between how to screen for depression, and then really delineating the difference between depression and kind of sort of a normative or normal sadness that children and teens will inevitably experience in their lives. And then I'll cover how we generally diagnose depression, how to approach treatment, including when to consider medications, referral to therapy, as well as consultation with CAP and with a psychiatrist. So first off, I just wanted to review a couple of statistics, and I know I'm preaching to the choir here because you're all working on the front lines and encountering youth with many mental health disorders on a daily basis. But overall, we think that depression is very, very prevalent. A lifetime prevalence for youth is estimated to be around 11%. And over the past year, about 7.5% of youth are estimated to have depression. In terms of the trajectory of major depression, we tend to see an increase as patients age. So the greatest prevalence of depression exists with adolescents, particularly older adolescents, compared to the younger school-age child. And as children age, we see greater increases in depression with females compared to males. And one of the reasons that we're so concerned about depression, not only because it is, highly impactful on youth and functioning and their day-to-day lives, but it is something that can be life-threatening. So 30% of youth with depression reported some form of suicidality within the past year, and about 10% of youth report a suicide attempt out of those who are diagnosed with depression. So it's something that is very serious, and intervention is crucial. As I'm sure many of you have also seen, depression rates are rising with time. And so statistics from 2005 to 2014 indicated that there was a rise in prevalence of depression. And more recently, with the pandemic and other stressors, such as social media and other factors related to screen time and technology, I think, clinically, what we're really seeing in our day-to-day is a tremendous rise in behavioral health conditions and depression as well. So, it's not clear what is really contributing to the increased presentation of depression for young people. It's thought that it could be related to social cultural factors, such as we mentioned, kind of increased use of social media or screen time, whether it's also related to heightened awareness of mental health disorders, or potentially increased screening and identification, or all of these factors combined. So I wanted to highlight that major depressive disorder is an episodic disorder, and it's thought to be recurrent. So we can see kids with depression who present in a variety of different ways, but generally we think of MDD as kind of having discrete episodes, and these episodes can last anywhere from usually between 1 to 2 months to 8 months. That doesn't mean that children don't have depression that lasts for longer, but I think when we think about overall statistics and looking at prevalence and how these episodes occur, they are supposed to be discrete. And we know that that treatment for depression through therapy and medications can reduce the length of these episodes. Some cases of MDD become chronic, and there are some risk factors for depression to present in the chronic form. So, for example, comorbid psychiatric conditions such as anxiety, substance use, personality disorders, can be associated with a longer length of a depressive episode. And we also know that comorbidity with other psychiatric disorders makes depression harder to treat and makes full symptom resolution less likely. And I'll talk a little bit more in another slide about kind of comorbidities and differential, but I just wanted to highlight that, generally it is episodic, but it can be chronic as well. And with the episodic nature, major depression can also be recurrent. So within about 1 to 2 years, there's almost kind of a 50% chance of recurrence of depression. And over the span of 5 years after an adolescent or a child has been diagnosed with depression, within 5 years, there's about a 70% chance of recurrence. So it is very likely to recur. Again, similar to the chronicity, there are some risk factors that increase the risk of recurrence of major depression. And that includes having a more severe depression, having other comorbidities such as anxiety, substance use, personality disorders, having residual symptoms that never quite go away, having psychosocial stressors like family dysfunction, ongoing stress in some other capacity or a history of trauma, or some cognitive stylistic differences such as negative cognitive style. That's sort of like the tendency to distort everything in a negative way. And so some of these factors can be changed or worked on through psychotherapy, but do increase the chance that depression will recur. So one of the objectives of today's talk was to highlight how depression can present differently along a developmental spectrum. We know that depression can occur for children of all ages. As I mentioned before, it's more likely to occur for adolescents, but it doesn't mean that a preschool child or a school-age child will not experience depression. And here in this table, I just wanted to highlight, some of the differences that you might see when a child of different age is coming to you and maybe potentially depressed. So in a preschool child, they may not be expressing sadness, but you may notice sort of an anhedonic presentation, absence of joyful play. In a school-age child, depression often presents more as irritability or temper tantrums or having poor frustration tolerance. They might be complaining of more somatic symptoms like a tummy ache or headache. They might be having more separation anxiety. They might even express hallucinations, and all of those can be signs of depression. And then in the adolescent age child, that's more of sort of the classic depression that we think about, somebody who's presenting very sad or having low mood or sleeping a lot, eating more, eating less, or having suicidal thoughts or sort of nihilistic attitude towards life. And just like depression can present differently with different ages, we also know that depression can exist along a spectrum. So depression looks different, from person to person. And for some, it can be more mild or subsyndromal. And for others, it can be quite severe. And I think one of the main questions that we often encounter in psychiatry, and I know that comes up for, pediatric primary care providers, is how do we know when it's depression versus when it's sort of everyday sadness or irritability? Because we know that sadness is a normal part of life. It's not uncommon for sadness to occur, especially in times of stress or in specific developmental stages, such as, during the adolescent period, where there's more of sort of an identity crisis or intimacy issues or issues with friends or peer groups or, again, social media. And so in psychiatry, what we're really looking for in terms of diagnosing depression is one, does the patient meet DSM-5 criteria for diagnosis, which I'll cover in a future slide. But two, I think the more important piece is how much distress are the symptoms causing and how is their functioning impaired. And so the realms that children function in are usually school, in the family, and with peers. For adults, we think about functioning in our workplace and with our relationships. And for our youth, it's really about sort of how are they functioning in school, with peers, and with their family. So before I talk about how to diagnose depression with DSM-5 criteria, I wanted to highlight the importance of screening, and going back to one of the original slides, about the, extremely high prevalence of depression. There's overall consensus that it is recommended that teenagers between the ages of 12 to 18 be screened for depression using the PHQ-9. Sort of a way to think about using this, the PHQ-9 is just thinking about cutoffs 5, 10, 15, 20. So if you've got a score of 5, there might be some mild depression, maybe subsyndromal, but there is some concern. A 10 is a positive screen for depression. And at that point, you're thinking that this patient likely has some degree of moderate depression. And then after the positive screen of over 10, 15 and 20 sort of tell you that you're looking at more moderately severe versus over 20 is a severe score for depression. And one question that often comes up is, what if you're concerned about depression or you want to be screening a younger child? The PHQ-9 is only validated for over the age of 12. And we recommend there's a short mood and feelings questionnaire, which is validated for the ages 6 to 12. So that might be helpful in terms of, kind of also assessing the types of symptoms that the patient is experiencing. So after you've done your screening, if there's some concern for depression, then it's really important to talk with the patient and the family members, and try to distinguish, kind of what's going on and get a sense of the severity and whether or not the patient has depression symptoms. And some of the general sort of pieces of advice or things that I follow is that I usually try to interview the patient and parent separately, because often the history can be very different when there's a concern about, a family member, a parent, or the teen overhearing. And it's important also to discuss teen confidentiality. There's some stigma about, talking about depression, anxiety, mental health concerns for some. So confidentiality is also really important in terms of trying to get as much of an honest answer as you can from the teenager. Sometimes teens don't volunteer symptoms spontaneously. So just really want to emphasize, don't be afraid to ask about symptoms. Don't, they're kind of taking their cue from you. So it's really important to just straight up ask about depression, ask about suicidal thinking and behaviors. And if you're sensing some degree of concern or reservation or stigma, it might be helpful to think about using normalizing statements, things like, I ask all of my patients this, or it's really common for, teens right now to be struggling with depression and sadness. And I'm wondering if, you're experiencing anything like that. And if possible, and I know this is, often challenging with sort of the limited time you have during your evaluation, but if there's other information from teachers, as I mentioned, parents or counselors or therapists, that can also be tremendously helpful in terms of understanding what's going on and if the patient's depressed. So moving on in terms of making the diagnosis, again, I think about, do they meet criteria for, in terms of the DSM-5 diagnostic criteria for major depression? And then on top of that, how much distress are they experiencing, how much functional impairment, and how mild to severe are their symptoms in terms of really kind of understanding what's going on. And just to review the diagnostic criteria, so you need these criteria within the last same 2-week period. So it has to have some sort of time. It can't just be for one day that they've been experiencing these symptoms, but over the same 2-week period, we're thinking about either depressed mood or loss of interest or pleasure, and then potentially also sleep changes, feelings of guilt, low energy, and then poor concentration. Sometimes that presents as, having difficulty making decisions. They just can't make any decisions for themselves. A change in appetite, some psychomotor change, whether that's more agitated or more lethargic, and any thoughts about death or having a plan or making an attempt. One thing that I wanted to highlight is that, there are a number of different conditions that can present like depression. So sometimes that can make, making the diagnosis challenging, or it can obscure the diagnosis a little bit. And at the same time, comorbidities are very, very common with depression, as I mentioned before. And so, there's both sort of the differential as well as considering what other conditions might be at play as well. So a number of medical conditions can sort of mimic depression, such as hypothyroidism, mono, anemia, autoimmune disease, chronic fatigue, migraine, epilepsy, asthma, some cancers. Some medications that are sort of depressants can also, mimic the symptoms of depression, such as using some anti-epileptic agents, steroids, birth control, alcohol, other types of substances. And then, a number of psychiatric conditions can also present similar to depression or be comorbid. So things like anxiety, PTSD, disruptive behavior disorder. Sometimes those types of symptoms can present with a lot of irritability that we see in depression, or at the same time, there can be sort of a withdrawal and sort of the negative neurovegetative symptoms, such as in psychotic disorders or autism. And just to highlight sort of the prevalence of having multiple diagnoses alongside depression, it's thought that anywhere from 40 to 90% of patients with depression have another psychiatric comorbidity, such as anxiety, disruptive behaviors, ADHD, substance use. And anywhere from 10 to 30% of patients with depression also have a medical comorbidity. And in particular, there's been kind of strong associations in the literature for youth with like neurological conditions, autoimmune disorders, endocrine disorders, GI disorders, and infectious diseases, metabolic disturbances, neoplasms, and nutritional deficiencies. And so in some of these, subspecialties, there's a very strong comorbid psychiatric component as well. In terms of treatment planning, so you've done the screening, you've made that diagnosis with the DSM-5 criteria, you've talked to the child and family about the diagnosis, you've asked kind of all the questions in an open and honest way, and you've sort of done your evaluation. Their distressed function and their functional impairment is their functional status is impaired. So the next phase is really kind of determining the appropriate treatment plan. And we really think about that as kind of understanding whether the depression at this moment is mild, moderate, or severe, and then tailoring the recommendations based on the level of severity. In mild depression, a patient does not necessarily need psychotherapy and or medications. There could be some active monitoring and just education about depression and what's going on, versus in moderate to severe, it would be really important to recommend psychotherapy and or medication and or a referral to psychiatry for further evaluation if there's other comorbidities or other things going on. So I mentioned active monitoring. That's usually looks like things like kind of talking about sleep hygiene and exercise and healthy food choices and self-care and things like journaling, behavioral activation, which is, really kind of encouraging the teen or the family to support the teen in getting out of the house, getting out of the room, doing things that create positive feelings towards the self, as well as, some relaxation strategies, particularly if the patient also tends to be on the anxious side, such as using belly breathing, or progressive muscle relaxation or imagery, identifying, a place that is very calming for them, or, kind of repeating some coping thoughts. And then in the realm of, if you're making a referral to psychotherapy, you might want to talk about the evidence-based treatment for depression in terms of therapy is cognitive behavioral therapy, that's CBT. And the premise of this particular type of therapy is that thoughts and feelings and behaviors are all interconnected and linked together. And in order to change our feelings, we can change our thoughts and behaviors. And similarly, our feelings influence our thoughts and behaviors in sort of a triangle. And it's a very sort of active participatory type of therapy where patients learn about, how to manage different thoughts and different behaviors in order to address the mood and the feelings. In terms of the moderate and severe cases of depression, you may also want to talk to the family about medications. And so for depression and for anxiety, SSRI medications are the first line recommended treatment for major depression. And there exists a lot of good evidence that 3 medications, fluoxetine, escitalopram, and sertraline, are safe and effective for children. Many organizations will recommend the first line to be Prozac or fluoxetine because there is simply much more data. That's the most well-studied medication for children and teens. And so, in many algorithms, you'll hear that fluoxetine or Prozac is the first medication to start with for treating depression or anxiety. And with all of these SSRIs, there's sort of a starting dose where you start the patient on a dose where they can tolerate some of the side effects. And then there's a ramping up period where you're increasing the dose until you're getting to a more effective dose. Generally, as you can see, there's quite a range of doses starting from the beginning to kind of the max dose. If you're curious about sort of the SSRIs, I know we also have specific webinars for kind of how to deal with SSRIs, how to titrate, and we're happy to talk with you about that through a CAP consult as well. Okay. Just want to pause there.
Thank you so much. So we will go ahead and transition into our case discussion.
So I can jump in. I'm not seeing the question, so I hope I'm not answering the wrong question. But in terms of the medications, the overall recommendation is that you start with one medication, pick one SSRI, optimize it in terms of getting to, kind of the max dose that you can with that medication, and waiting, unfortunately, at least 6 to 8 weeks for benefit. And then if that's not working, then the next steps are either choosing an alternate SSRI or there could be potential benefit from choosing an SNRI or, thinking about other medications such as Wellbutrin or, mirtazapine, although the non-SSRI SNRIs, there's not much evidence in the pediatric population. And in terms of combining 2 medications, overall, the recommendation is to just use one SSRI unless the patient has failed trials of monotherapy, in which case there might be some role for augmentation. But in general, we haven't found that starting off with 2 medications augmentation leads to improved outcomes faster. It tends to risk more side effects and interactions.
And then there was another question about kind of thinking about medication for insomnia in this case.
Yeah, I just wanted to really emphasize the point that Dr. Steinbushel made before, which is it seems like there's a, definite feeling of like an inability to intervene from the parents, like a feeling of helplessness. I think, in these types of cases where kids are on their phones until 3 or 5 in the morning, the first line approach, instead of using medications, is to have parents set boundaries, whether that's making rules and having the kids follow them, or locking up the laptop or disconnecting the internet service. Presumably, he's not functioning independently and making his own money and paying for all of these things. So, parents as parents still have some power. And I would definitely try to explore that first line before, thinking about like intervening in terms of medications for sleep, because it's not clear that, at least to me right now, that it's like a sleep issue. It seems like he's having a lot of fun, playing games. It's really addictive, and maybe his friends are online or playing until 5, they're in different time zones or whatever. That would be the first place to talk with parents about.
Yeah, I
One,
agree. And I think especially it sounds like he's actually getting enough sleep. It's just it's shifted very late. And it's, I think for me it's sometimes helpful to also keep in mind or even talk with parents when we think about like as full-grown adults, how hard it is to put down our screens and go to bed and how easy it is to kind of get sucked into them. And then we're asking, a teenager who doesn't have a fully developed frontal lobe and in addition is also in addition to just being a teenager is dealing with depression and anxiety. And I think Dr. Burke, you characterized it so well of when we're feeling really bad internally, that the distraction of the screen can kind of temporarily kind of distract us or dull that feeling. And so then it can be even harder. Like I've had that myself. Sometimes I'm like doing something on my phone. I'm like, why am I having so much trouble stopping, getting off my phone? And then I finally do. And then something like a patient I'm worried about pops into mind. I'm like, oh, that's why I didn't want to stop playing on my phone because my brain knew there was anxiety back there waiting to pop up. And so sometimes that helps parents to realize like it's kind of not fair to be asking teens to be regulating this on their own. That's too hard.
along the lines, the first question, is there a place for something like melatonin or delayed phase sleep disorder? The only time I've ever tried it was when I had someone who was highly motivated to make a change. But other than that, I know that people quickly develop a tolerance for it. And when I've spoken to sleep doctors, they talk about both using doses that are, I guess, pharmacologic, more of 30 to 60 minutes before, but also very tiny doses to affect circadian rhythm probably 6 hours before. So I just thought I'd put that out there and have you guys who do it more than I do perhaps comment and try to answer about
Yeah.
medication being appropriate for a sleep disorder, for insomnia.
Yeah, in this case, I think it would be reasonable to consider a chronobiotic dose of melatonin. So that's sort of like a very small, like 1 milligram tablet, a couple of hours before bed for the purpose of regulating kind of the sleep wake cycle. And I think if I were talking to this family, I would say, here we can go ahead and try this. This may help with the circadian rhythm and getting him back to, kind of a regular sleep wake cycle. And I don't expect it to do, like, it's not going to be a magic pill. I think the other piece that they really need to take responsibility for is, kind of shutting down electronics at a certain hour. So I would almost offer that as an olive branch. Like, I want to work with you. We could try multiple strategies together to tackle this, but one is not going to, make all the difference if it's not going to like knock him out so that he's not using electronics. But, I think you've demonstrated so nicely, the value of like aligning with your patients and aligning with families. So I think that, if they were asking about melatonin, if they felt like this could be something really helpful, I think building that alliance and, using melatonin, which is, safe and, not likely to cause side effects, would be something that would be very reasonable to consider.
I think you hit it very well because I brought this up very briefly, but because the family resists all medications, I was going to pick and choose where I said, yeah, okay, then it's really important you just stay on the other one.
Yes. Yes.
Yeah.
I think that makes total sense. If they're already, very wary of medications, then you really have to prioritize.
Mm.
Yeah, and I think in terms of your question about what do we do from here, he's doing better, but he's not, 100% cured, not fully, experiencing resolution of symptoms. You did mention that he now is working with a therapist. Is that right?
Apparently, yes, as far as I found out, that he'd been seeing a therapist 2 to 4 times a month, which I'm hoping provided him with better insight. I don't know if it's cognitive behavioral therapy or if it's talk therapy, but it's something that he has another person that he can trust to talk about these things.
Yeah.
And so I can try to explore it further, and also with parents asking, what are the goals? What are you guys trying to do as far as trying to change behavior so he has a better chance of succeeding at actually attending school versus all the challenges he has now.
Yeah. Yeah. I think
What
that-
about continuing medication? Yeah, as far as that, it is, I'm, I, I just wanted to, yeah, I'm very concerned about him stopping, and I'm worried that, I said, if you stop, even if it's against my medical advice, I will still support you, but I am very concerned that that is not the right choice.
Yeah. I mean, I think in some ways that's all you can say. And as long as you're clear and consistent about that, and, really sharing with them the concerns and the downsides of stopping, then, you can't really put you're not giving him the pill every day, right? That's out of your control. I think what, Petra mentioned before, just about understanding, like, the parents are so worried about giving this to him. What are the risks of taking it for 2 more months? What are the risks of taking it for 6 more months? Just wondering if there's something that they're thinking about that they're just not communicating for whatever reason. Because it seems like they're aware and they're hearing you in terms of the benefits and what you're worried about. I guess I'm still just sure about
Yeah, I think, and I get the feeling, like, this is where I start thinking that myself, to some degree, and parents even more, are really enabling. Whatever he wants is what's going to happen. I think that if he wanted to be on medicine, I think the parents would be better with being on medicine. I'm not sure they really object. I think, but I am much more worried about the fact that they're just not saying, no, we think this is the best and your best medical entry. They won't even come to that. They're just sort of following his lead and kind of working with it. So, but I'll try to explore that further, because the next time I meet him, these are things that we're going to be asking.
And it might too, sometimes I don't get that sense that this is what's happening in this case, but I would, with teenagers that are kind of vaguely wanting off of the medication but aren't telling me why, I always make sure to explicitly ask about sexual side effects, because sometimes they may be experiencing that and that's not something they are comfortable volunteering. So I keep that in mind if they're kind of vaguely just, they want to be off of it, but they really can't give me a clear reason why.
Thank you.
Yeah. And Stephanie, I think in the chat you asked about, is he at withdrawal symptoms, and kind of how would he stop it? So with sertraline 50 milligrams, it's a low enough dose that he could just stop it we wouldn't be concerned about really withdrawal symptoms in his case. Our concern would be worsening anxiety and depression since it's only partially treated at this point. That's tough. Yeah, I mean, I agree with what you're saying, that I definitely continue to encourage them to take it and kind of try to explore some about what the concerns are currently. Are there side effects that he's not disclosing?
And I like what you said about goals. Like, what are his goals? What does he want to do? Does he want to be like the champion of StarCraft or something? Because that's a fine goal too, but he's got to do some things to get to that goal.
So I just want to say thank you, for a patient. And I know there's other people who may have been waiting to ask other questions, and I want to make sure that they get an opportunity. But thank you so much for everybody's input. Take care, guys.
Thank you. Bye. I think we are pretty much at time here. So we'll go ahead and wrap up. Michelle, thank you so much. It's great having you here today.
Thank you.